We will now examine the costing methodologies that are generally in vogue. Costing methods are in continuous evolution, and there are about 6 of them that are common in the healthcare industry, and some are better than the others. I have a personal favorite, and I'll mention that towards the end of this video. But there are 2 things. So that you have to balance between accuracy, practicality, and the ease of implementation. And these are the factors that need to be considered when you choose the costing methodology that might work best for your healthcare system. In this slide, I will list some of the popular ones and very briefly explain each of these methods. So the first one is probably the most common, and it's called TCS. It stands for the Total Cost of Stay method. It's easy, straightforward, doesn't require too much financial investment. Because it's easy to implement, people generally tend to use this very widely. It is also easily understood, easily applied. The only challenge with this is the accuracy can be fairly low. The second method is called ABC. It stands for activity-based costing. So what happens here is activities and resources that are involved are considered for costing, and the indirect costs are tracked and allocated individually. But as you can imagine, this requires a lot of time from managers and significant expense for implementation and maintenance. It's definitely a lot more accurate, but because of the practicality challenges in terms of expenses of implementation and maintenance, you do not see this being used as widely as, let's say, the TCS. You have another method which is called the CCR. It stands for Cost to Charge Ratio. And this is a costing method that is specific to the healthcare sector, does not require significant expenses or management time from an implementation standpoint. Basically, this is a costing method that allocates costs to patients, services, or departments based on the ratio of actual costs to the charges, right? And accuracy is questionable, modest at best. The fourth is economic costing. It basically requires a careful assessment of the opportunity costs. And some of the costs that do not appear in accounting cost reports can be included because we include the idea of opportunity costs, which is sometimes not included in a lot of accounting statements. It's not a direct method as compared to some of the others that I've just listed to develop overall costing, and financial analysts sometimes insist on including opportunity costs because they want to differentiate between what is accounting profit and what is economic profit. This method requires careful assessment of opportunity costs, and some of the costs that do not appear in accounting are included. This can lead to some level of subjectivity, not so widely used, but has some significant advantages in my mind because the idea of economic profit is an elegant one and sometimes is missed because we only look at accounting profit. The fifth is called RVU, or Relative Value Units. It's also called the Resource-Based Relative Value Scale, RVS. It is based on the complexity of the procedure, the costing method, the volume of resources that are consumed, and the duration of care. So basically what happens in RVS or RVU is that the method assigns a relative value to each service or procedure based on the quantum of resources required for delivery. And as I just mentioned, because it is based on the complexity, quantum, and the duration, it is very accurate but can be cumbersome to implement. The one main drawback that people might point out with RVS is that it is subjective. and there is an inability to reflect changes in process, workflow, and technology. It can be widely used when there are demands and purchases of new and expensive medical equipment, especially, let's say, if there is demand on the management to purchase a new MRI machine, then I suspect this might be a fairly good costing method to make the decision on the additional capex purchase. The sixth is called the TDABC. It stands for Time Dependent Activity Based Costing. This method is particularly used to measure detailed costs of specific procedures or clinical conditions along the entire cycle of treatment. It is an extension of ABC, which is activity based costing, number 2 on this slide. And then there is an added dimension of time. So, time dependent ABC, time dependent activity based costing. We will now examine, or I will now share with you why I personally think TDABC must be the preferred mode of hospital costing. I admit it's a bit cumbersome, but if you really want significant savings that can be directly related to process improvements, this particular method probably serves us the best. In my mind, the TDABC, the time dependent activity based costing, must be the preferred mode of costing or the methodology when healthcare systems determine which particular option to choose. I admit that it is cumbersome and it's probably also practically difficult, but the investment in this effort on TDABC can return rich dividends and real insights into efficiencies and also outcome improvements. It's also one of those few methods that can really bring the doctors into the costing process. Otherwise, the doctors are not involved and it is done by bean counters sitting in the administration wing. But TDABC, because it focuses on the entire life cycle of the treatment, will ensure that the doctors are also part of this effort and initiative. This method also provides the most accurate costing picture to the hospital management amongst all of the 6 methods that are generally available. This work is based and it originated from a work that was done by Professor Michael Porter, and it was published in the Harvard Business Review, and they actually provided case studies with a step-by-step approach of conducting TDABC in hospitals. Towards the end of this series where I present a module on how to start a hospital, I will include the case study as one of my slides in the video, but for now, you might want to Google and access this seminal work by Porter, Kaplan, and I think it was Witkowski. The ability to identify value improvement opportunities in healthcare can be best done through TDABC. I'll also give you another practical reason why we should adopt this method over the others. You see, most of the times, hospital is seen as individual units, right? Different departments: cardiology, neurology, pediatrics, endocrinology, metabolic diseases, etc., etc. And hospital management has this tendency to look at each department individually and their P&L, and also the outcome and the physician and sometimes payment systems are linked to these individual departmental P&Ls. But you see, some departments, by its very nature, might seem more profitable or highly revenue generating. So, for example, an endocrinologist or a neurologist, a pediatrician or a renal physician, absolutely key disciplines, might not on paper seem as profitable or generate as much revenue, let us say, as a cardiac surgeon or an orthopedics or even radiology. Now, as an example, for example, the lab and diagnostic revenues that are prescribed by a general physician can be significant. But these revenues are sometimes not apportioned to these departments. But what happens is that the cost, the overall fixed cost of that hospital, is allocated equally sometimes using what is known as a peanut butter approach. So this makes certain departments look a lot less profitable when that might not really be the case. Let me explain this with the example of a rehab center. So let's say a patient has had a complex, brain surgery or an orthopedic surgery and is undergoing rehabilitation. Patients generally tend to stay a long time at the rehab center, relatively. So the average length of stay, ALOS, is much higher. But then the rehab center does not demand as much attention on the patient as, let's say, when the patient was in the acute care facility, immediately after the surgery, for example. But the support fixed costs that you might see when it is allocated, it's allocated to rehab using the same method that it is done for an acute care facility, right? Where the demand, attention, costs, everything is high. Now, this complicates things and causes dissatisfaction among physicians because their compensation can get affected. And their department might look a little dismal when you just look at numbers without looking at anything else or understanding this, right? And I also think that because hospitals are using, what should I use? Not so evolved costing methodologies or poorly done, not so scientific costing methodologies, it drives a wedge between medicine and surgery sometimes, between doctors and administration, and just increases the conflict. And it also leads to an invisible turf war between medicine and surgery. So, for example, a patient who needs a cardiac intervention, if we don't use the right costing method and the right compensation plan, we'll get to this later, there might be a tendency for the cardiologist to probably intervene with procedures when probably an open heart or a bypass, a regular traditional bypass, could be a better choice, right? So all of this can impact the outcome, it can impact the decisions taken, and therefore, a lot of hospitals, when they use poorly designed costing methods, anomalies creep in, hospitals destroy overall value, and by focusing on highly paying or highly reimbursed services, they also tend to somehow celebrate cardiac surgeons, compensating other surgeons based on revenue generation or profitability, and this can lead to major distortions in the supply and efficiency of care.